Good morning. My name is Megan. I'm one of the medicine chief residents, and today I have the pleasure of introducing our speaker, Dr. Thomas Marron. Dr. Marron is the director of the Early Phase Trials Unit at Tisch Cancer Institute and a professor of immunology and immunotherapy, as well as professor of medicine, hematology, and medical oncology at the Icahn School of Medicine. He holds a PhD in immunology and is a practicing thoracic medical oncologist. His research program focuses on the development of novel immunotherapies and combinatorial therapeutic approaches for solid tumors. He leads a translational oncology bench-to-bedside-to-bench program in partnership with Miriam Murad and her laboratory focused on developing novel therapeutic approaches and repurposing available biologic therapies. Please join me in welcoming Dr. Marron.
Thank you so much. It's always a pleasure to come home to Department of Medicine Grand Rounds. I'm going to give a little bit of an update on cancer immunotherapy and how we're using these now to treat solid tumors as just standard of care. And then I'm going to talk to you about some of the research that we're doing to try to move the bar somewhat so that we can improve outcomes for our patients. These are my disclosures. I'm a phase 1 doctor. Everything I say is off-label, so do take it with a grain of salt. So I always like to take a step back when we're talking about immunology because my father tells me that immunologists talk in their own foreign language, and it's good to get everyone on the same page going back to medical school and really thinking about the immune system as this dichotomy between the adaptive and innate immune system. And both of these are extremely important for defending us against microbes, but also for defending us against cancer. And they're also being hijacked by tumor in a variety of ways. So you'll see I'm going to discuss all of these different players, both the adaptive and innate immune system, thinking really about your T cells and your B cells and the humoral component of the immune system, as well as the innate immune system, which is really the focus of a lot of our work, specifically looking at phagocytes, both neutrophils and in particular macrophages, which make up a good chunk of the tumor. And within our body, in a, sort of an evolutionarily conserved way, there's this very delicate balance between activation of the immune system, hopefully against foreign antigens, and a variety of tolerogenic signals that really keep our immune system from attacking our normal tissue. Obviously, tolerogenic signals are what's happening 99.99% of the time because we're not constantly being exposed to foreign microbes or cancer. But as we get older and as we hang out in the sun and live in New York City and smoke cigarettes, hopefully no one here, we have this process of carcinogenesis where you're developing more and more mutations in our tissue all throughout our body, and many of our cells are actually looking more and more foreign and more recognizable to the immune system. And every cancer is caused by mutations. This is at the heart of any sort of malignancy, changes in your DNA. And a very small subset of mutations actually result through translation and transcription and translation into mutated proteins. And these mutated proteins are what actually make a cancer cell visible to the immune system because it's the one thing that really differentiates a normal cell from a cancer cell. And it's these mutated proteins, or what we call neoantigens, are things that your body hasn't been tolerized against in your thymus and through normal tolerogenic mechanisms. And the way that your immune system is taught what to recognize is really through antigen-presenting cells, and particularly the dendritic cells, which are the most potent cross-presenters of antigen, the most potent antigen-presenting cells. I always call them the professor cells of the immune system. And we have dendritic cells all throughout our body, in our brain, in our skin, in our guts, and they're constantly sampling the microenvironment, making sure that there's nothing to be concerned about and figuring out if there's any antigens that they should be, alerting the immune system to. So your dendritic cells are constantly taking up antigen from dying cells, whether that be pathogenic death or just normal turnover. They're internalizing these, and at the same time that they're taking in antigen, they're sampling the microenvironment using a variety of innate immune receptors, like toll-like receptors, both on the cell surface and in the endosome. And that's really telling the dendritic cell if there's any sort of alarm signals that they should be aware of, or if this is just normal cell turnover, and you really should, exert a tolerogenic signal. And these dendritic cells then traffic antigen either through direct presentation to MHC class 2 or cross-presentation to MHC class 1. And this directly presents these antigens to either CD4 or CD8 T cells, respectively. And at the same time that you're seeing this sort of interaction through the MHC and the TCR complex, it's really this signal 2, which is actually a slew of different signal 2s, but it's the second signal, not the signal that, this is the antigen, it's the signal whether or not this is something to be worried about. And so really, if you're having an alarm signal, like if the dendritic cell is sensing bacteria or viruses in the microenvironment, then they'll upregulate signals that will activate T cells against foreign antigen. So if our immune system is able to recognize foreign antigens, why aren't all cancers immediately removed from our body? And typically they are. So everyone in this room right now probably has lots of cancerous cells in their body, and by the time you get to dinner, those are all going to be gone, and tomorrow morning you'll have all new cancers. The problem is that eventually you'll have a cancerous cell, particularly as you get older, that's really able to evade the immune system, and it does this through a variety of mechanisms. One of the mechanisms that we know most about, because we have therapies to disrupt it, is something called PDL1. So this is programmed death ligand 1. It's basically a stop sign that cancer puts up and says, hey, I know you recognize me, but don't attack me. And it turns those T cells off, even though the T cells have been adequately taught what to recognize. And the way that we unhijack the immune system is we really disrupt these off signals. And we'll go through, there's a bunch of different off signals, but PDL1 is one of them. And we have a variety of therapies that are FDA approved that you're seeing people in the hospital with the bad sequelae of that turn off this off signal and really allow the immune system to do its job and kill the cancer. So checkpoint blocking antibodies, they really revolutionized the care of cancer patients. And in some cancers, they're curing previously incurable cancer. Everybody has heard of these at this point. One of the most famous people to have received checkpoint blockade is Jimmy Carter. It's his 100th birthday today, thanks to his anti-PD-1 therapy. He was cured of metastatic melanoma to his brain over 10 years ago. People all know about these also because they advertise them constantly on Monday Night Football and everywhere else under the sun, and they have all these ridiculous names that no one can pronounce. And you'd think based on the advertisements with grandmas running through the fields that we're curing everyone. And we are curing some people. And so this is one of the first studies that came out of the melanoma group at Memorial Sloan Kettering, where they were looking at melanoma, patients with metastatic melanoma, which had a average survival of less than a year. And this was a uniformly fatal diagnosis. And here they randomized patients to receiving dacarbazine, which is a chemotherapy that no one in this room that's training has ever heard of because we don't use it anymore. It's a very bad chemo, very toxic chemo. I gave it once as a fellow to an inpatient. So they either got dacarbazine or nivolumab, which is an anti-PD-1. You can see here these Kaplan-Meier curves split in a really nice way, much better than just about any other therapy we develop in medicine. And additional therapies have been developed and added on to nivolumab. So now a standard care for metastatic melanoma is nivolumab and ipilimumab, which is a CTLA-4 antibody. And here you can see they have really impressive improvements in survival. And the most exciting thing about these Kaplan-Meier curves, and again, this is a universally fatal diagnosis back in 2012, is that we're seeing plateaus form. And when you see a plateau form on a Kaplan-Meier curves, it means you actually might be curing some of these patients. And we still are always hesitant to use the C word, cure, with our patients because we don't want to guarantee them anything. And this is something that we weren't used to doing with patients with metastatic disease. But in 2024, we're actually curing about 50% of patients with metastatic melanoma. And I'm technically a lung cancer doctor along with being a phase 1 doc. So on Fridays, I see lung cancer patients outside of clinical trials, and I give them a combination of chemotherapy and pembrolizumab. So chemotherapy, this was the trial that set that up. And in red, you see with chemotherapy, the median overall survival, similar to melanoma, was less than a year. But when we added on pembrolizumab, we more than doubled the survival of those patients. So it means our clinics are more than twice as full as they were in the past. It's super amazing to see these responses. But unfortunately, I'm not retiring anytime soon because the majority of our patients are still dying of this disease. And really is one of the reasons why we're working in the lab and in the clinical trials program to improve on these therapies that we've been developing. So the issue is that I showed you that one stop sign that cancer puts up, the PDL1. The issue is that there's a whole slew of different stop signs and go signs within the tumor microenvironment. And we have drugs that target just this very small corner of the immune response against cancer antigens. But there's a slew of these on and off signals. Really, the on signals are activating your T cells, your natural killer cells, your humoral immune system, your macrophages to kill cancer. And then there's all these off signals. And these are tolerogenic mechanisms that are really evolutionarily conserved. This is part of the way in which our body doesn't have, massive autoimmunity and inflammatory diseases at all time. But these are a lot of the ways in which cancer hijacks the immune system is they upregulate these off signals and they downregulate the on signals. And along with, these drugs for PD-1 and CTLA-4, we have clinical trials here at Sinai and elsewhere as well that are targeting a slew of different on and off signals, both within the tumor microenvironment and also within the interaction and that education synapse between between T cells and antigen-presenting cells, which, as I said, are kind of the professor cells. And if you zoom in just on this little synapse right here, we have a slew of these receptors and ligands, and it's really the constellation of all these on and off signals that tells the T cell whether to turn on or turn off. So this isn't a black or white thing. It's really 50 shades of gray, and all of a sudden you're going to be more towards on or more towards off, and that's what's going to kick off a CD8 T cell to be cytotoxic versus exhausted and not attack its target. So therapeutically, we can modulate these on and off signals. The drugs that we already have that are FDA approved are really antagonistic antibodies. So these are negative receptor ligand interactions. So by developing antibodies that sort of separate those and block that, just sterically inhibit that interaction, you turn off one of the off signals so that the on signals outweigh the off signals and you're able to activate your T cells. And conversely, we can actually use agonistic antibodies. So here, you want these receptors and ligands between the T cell and your antigen-presenting cell, like your dendritic cell, to interact to turn on both the APC and the T cell. And here you can use antibodies to kind of mimic the interaction. So you're sort of tricking the T cell who's expressing CD40 ligand to thinking that they see a CD40, and that turns the T cell on, or vice versa. So this sort of manipulation of the immune system is really at the heart of all the cancer immunotherapies that we've developed. Just a brief word, since it's very applicable to all of our medicine colleagues, is that checkpoint blocking antibodies, they do have significant risk. And these are the risks that oftentimes we're seeing in the hospital. I have a patient on 9 West right now with pretty serious pneumonitis. And what happens is, if we're either taking off these stop signs, we're taking our foot off the brake, or if we're stepping on the gas, what can happen is that you can develop inflammatory reactions. These aren't specifically autoimmune per se. Some rheumatologists don't like us using that terminology. I sometimes call it autotoxicity. There's a variety of different mechanisms of inflammation that can result, and we can basically give you an itis of any part of your body. And so I've probably given hundreds of different itises at this point with these therapies. All of these side effects are extremely rare, which also makes it hard to predict who's going to have them, and it's also very difficult to study how we treat them just because they are so rare and their timing is so varied from one patient to the next. And you can have a patient who can get one of these itises 3 days in. Typically, it's 8 to 10 weeks that patients develop these, but I also have had a patient that developed nephritis 18 months after starting pembrolizumab. So it's very unpredictable. One note that I always like to tell patients as a silver lining if I end up having to hospitalize them is usually if these patients develop immunotherapy-related adverse events, these tend to be the patients that actually do the best. So there's been many studies across many different tumor types. The data is not perfect, and there are some negative studies, but our group, where we have one of the largest HCC programs in the world outside of Asia, we looked at our cohort and combined it with a group from Imperial and from Dana-Farber, and we saw that the liver cancer patients who developed immunotherapy-related adverse events had a much better progression-free and overall survival. And we actually validated this with a large FDA cohort. So I do think I always try to put a silver lining, and I give patients a high five as I send them to the emergency room for their colitis or pneumonitis or what have you, because maybe their cancer's gone. So as I mentioned, it's super fun being able to cure patients every once in a while and definitely keep them alive longer. But the goal of our work is really to figure out how we can cure more people. Obviously, our goal is 100%, not 20%. And this is my current treatment paradigm for lung cancer patients who don't have driver mutations. So these are typically the smokers that come see me with metastatic cancer. And we use PD-L1 staining, which is just an IHC staining for how much of that stop sign is on the tumor, to dictate what cocktail of immunotherapy and chemotherapy or double immunotherapy we might give patients. And like I said, we're more than doubling the median overall survival of our patients, which is super gratifying. But we obviously have a lot of room for improvement. And as I'm an immunologist, my focus is entirely on finding other ways to harness the immune system. And we're really doing two approaches. So one approach is to find new ways to induce de novo T cell responses. So if you give somebody a drug that takes your foot off the brake, but your car is on a flat surface, the car is not moving anywhere. So if you haven't taught your immune system what to recognize, if you haven't had a vaccinal effect and educated your T cells what to recognize, you take your brake off that T cell and it's just gonna sit there and not do anything. And so a lot of the approaches that we're doing, and we're opening a bunch of Moderna vaccines where we're using neoantigen vaccines to induce de novo immunity, and that's particularly important for patients who have PD-L1 negative tumors. So that's really a marker of patients that don't really have any recognition of their cancer. We can also use CTLA-4 blocking antibodies like Dupilumab to induce de novo T cell responses. Those come with a lot of toxicity though. And so it's always a delicate balance. But the one thing is we have to induce, a new immunity. We have to teach the immune system what to recognize. But even if you do that, sometimes patients don't respond. And what our work really focuses on is harnessing the rest of the innate and adaptive immune system. Because if you take a tumor out, if you take a lung tumor out and you cut it up and you look at it under a microscope, sometimes there's actually more immune cells than there are tumor cells, which really underscores two things. One, this is obviously a disease of the immune system if there's that many immune cells there. And the other thing that's really striking is if you look at the immune cells, all of our therapies that are FDA approved to date, and probably 90% of them that are in development, are focused on your CD8 T cells, which are your targeted cytotoxic T cells. But the majority of immune cells are actually myeloid cells. So they're neutrophils and macrophages. You don't even see the neutrophils here because they're hard to study. But macrophages make up about a half of the cells that we see when we cut out a tumor and we look at it under the microscope. And we know that these macrophages are not the normal macrophages you see within tissue. So these are not tissue-resident macrophages, like alveolar macrophages in the lung or Kupffer cells in the liver. These are actually monocyte-derived macrophages. And this is work that's really come out of Miriam Murad's lab. She studies ontogeny of these cells. And they've really beautifully characterized this concept of emergency myelopoiesis. So emergency myelopoiesis is basically when your bone marrow gets revved up due to some sort of emergent stimuli. So infection like COVID causes emergency myelopoiesis. That's why everyone had so many myeloid cells that led to the massive inflammation that we saw in our patients, particularly in our older patients who have basal emergency myelopoiesis. But emergency myelopoiesis is also a response to stimuli from cancer cells. And it's actually one of the many ways in which cancer is really hijacking our body and taking over our immune system. And the theory, I'll show you some of the data that supports this, is that cancer is really secreting a variety of cytokines and chemokines into the blood that traffic to the bone marrow and basically hijack the bone marrow, and they lead to this emergency myelopoiesis, meaning it's an expansion of your myeloid progenitors in particular. These immature myeloid cells are then dumped into the blood and they traffic into the tumor where they set up shop and they're really polarized into bad myeloid cells. So these tumor-associated macrophages or monocyte-derived macrophages, which are extremely immunosuppressive and really turn off the T cell benefit. So even if you taught a T cell what to recognize, if you have a tumor that's chock full of very immunosuppressive macrophages, those T cells aren't going to be able to do anything. And we've been studying these macrophages for a while, and many people have tried basically just to deplete macrophages from the body. And that doesn't really work because you're kind of throwing the baby out with the bathwater, because macrophages are one of your most important antigen-presenting cells. They're extremely important for anti-tumor immunity also. So you can't get rid of the good and the bad. And we really focused on trying to identify very specific programs and phenotypes of the bad macrophages so that we can learn how to either deplete those or potentially repolarize them and turn them from bad guys into good guys. And we've done extensive single-cell analysis of untreated human non-small cell lung cancer, and we see very similar programs in colon cancer and liver cancer, basically everywhere we've looked. And what we see is that they're the very immunosuppressive monocyte-derived macrophages, when you look at their transcriptomic signatures. So transcriptomic means we're looking at the RNA, and every cell in your body has the same DNA. It's really the RNA signatures that tells us about the functional specificity of those cells. So we can identify the monocyte-derived macrophages from their very immunosuppressive phenotype, and then we look at other signatures within those cells to see how we might be able to target them. And one of the things that we see is there's this very strong IL-4 signaling signature within these cells. It seems like these cells are somehow being polarized by the cytokine IL-4, and it's activating this whole downstream pathway from the IL-4 receptor. And interestingly, we look at a mouse model. This is the murine KP model. So this is KRAS mutant P53 deficient lung cancer in mice. It's kind of like we're having our mice smoke cigarettes because it looks very similar to what we see in smokers. And interestingly, they also have this very strong IL-4 signaling signature. And as I said, we're also very interested in dendritic cells. These are the professor cells of the immune system. And so we've done, really exhaustive single-cell analysis of human lesions as well as these mouse lesions. And the pink is human and the brown is mouse. These are all individual dendritic cells, each of these rows. So what we can do is we can identify the different dendritic cell subsets by looking at their transcriptomic signatures. And we can see these DC1s. This is the most potent cross-presenter of antigen to the immune system. These, Miriam's lab about 10 years ago showed are absolutely necessary for response to nivolumab or pembrolizumab, all these fancy drugs I've been telling you about. So if you don't have these, you don't respond to checkpoint blockade. So we identify these DC1s, DC2s, we still don't really understand what they do, so we're working on that. But one other subset of dendritic cells, a small subset, but we see it in both humans and in mice, and we see it across all tumors that we've looked at so far, is this population of dendritic cells that you can see here from the transcriptomic. This RNA signature looks totally different. You don't really have to understand this plot to see this group looks different from this group, looks different from this group. So this group, these MREG DCs look very different, and we call them MREG DCs because of their functionality. And what we were able to do is we were able to use a model where we had GFP-labeled tumors. So these are basically green tumors. And so you can actually see which of the dendritic cells have gobbled up tumor antigen versus those that have gobbled up normal antigen or haven't gobbled up anything at all. And if you look at the dendritic cells that have taken up the green antigen, so we can sort them and say what's green and what's not green, what we realized is that those green ones really are these MREG DCs. And so the MREG DCs really represent dendritic cells that have already successfully sampled some antigen, specifically tumor antigen. And what you're seeing is these dendritic cells have a very strong upregulation of a maturation signature, which that is normal when dendritic cells take up antigen, they mature, they stop eating, and then they start processing it. They upregulate regulatory markers, and this is, again, a normal homeostatic mechanism because most of the time, 99.99% of the time, when your Langerhans cells in your skin are sampling antigen, it's just your own skin antigen, and you want them to tolerize T cells against that because otherwise you're going to get all the scary pemphigus and inflammatory diseases that you have within your skin. Cancer really should be activating these dendritic cells, but the cancer is really able to co-opt the system and induce this regulatory tolerogenic phenotype. But interestingly, we also saw this very strong type 2 signature. So I just showed you that these monocyte-derived macrophages, the bad guys, have this strong IL-4 signature. IL-4 is the canonical type 2 cytokine. And here we also see lots of IL-4 receptor alpha and other members of the type 2 signaling pathway. So when I'm talking about type 2 immunity, what exactly does that mean? So in general, we always like to make things black and white, and they're never quite that simple. But back in medical school, I learned about type 1 immunity and type 2 immunity. And type 1 immunity is super important for antiviral responses, so anti-COVID, anti-cancer responses, while type 2 immunity historically and evolutionarily was very important for anti-helminth responses. But because we use so much Purell and bleach here in New York, we don't have a lot of helminths challenging our type 2 immune system. And sort of the cornerstone of the hygiene hypothesis, where we're not being exposed to all these helminths that we would have been back in the day, now you sort of have aberrant activation of the type 2 immune system, and that's why we have all this atopy that we now see in patients, particularly in children. So this is the reason why kids can't have bake sales anymore, because your type 2 immune system has gone haywire. But we also know that, while type 1 immunity is very important for anti-tumor immunity, it seems like type 2 immunity is very pro-tumorigenic. And this is a concept that's been known for decades at this point. This is just some data looking at patients with pancreatic cancer. So these are patients that are not getting immunotherapy or anything, they're just getting chemo. And we know that patients, and this is seen in pancreatic cancer, breast cancer, lung cancer, patients who have a stronger type 2 signature systemically, so more type 2 cytokines, like here we're showing IL-4 and IL-5, two canonical type 2 cytokines. If you have more type 2 cytokines in your body, your cancer grows faster and you do worse. So we knew that type 2 immune responses really portend worse survival and really help cancers grow and metastasize. And some of the most important preclinical work has come from Lisa Cousins, who's the immediate past president of the AACR. And her group about 15 years ago published this first paper where they were looking at a breast cancer model. Again, this is mouse data, but they basically took tumors out. They looked at those T cells in the tumor, and they saw that those T cells had a very strong type 2 signature. So they make, again, lots of IL-4 and not enough interferon gamma. So this is the type 1 cytokine, this is the type 2 cytokine. So you seem like you're having a tilting towards the type 2 end of the spectrum. And interestingly, when they either blocked where they knocked out the IL-4 receptor, and it's IL-4 receptor alpha, which disrupts not only IL-4 signaling, but also IL-13 signaling, which is another type 2 cytokine, very important for a variety of atopic conditions. Or if they use a neutralizing anti-IL-4, you actually see a significant decrease in the growth potential of these tumors and the metastatic potential. So what does this have to do with treatments we're giving breast cancer patients? So they then looked at the standard therapies for breast cancer, at least back in 2015, which were really just radiation and chemotherapy. And they actually saw that anti-IL-4 synergizes with radiation or chemotherapy. So it seems to rev up the response to these very toxic stimuli to increase the likelihood that we're able to cure or at least eliminate or slow the growth of tumors. So these are old-fashioned ways of treating cancer. I always try to avoid radiation and chemo when I can because they're very toxic and much more toxic than immunotherapy. So we wanted to say, well, what happens when you give immunotherapy and you block IL-4? So we use this KP model that I mentioned earlier, kind of like a smoking model in mice. And these mice really don't respond at all, or this tumor rather doesn't really respond at all to checkpoint blockade. So it's a very resistant tumor, and many of our patients have primary resistance to these therapies. But interestingly, when you take these mice and you give them anti-IL-4, it significantly decreased the growth potential of these tumors. So we're just neutralizing a cytokine, and all of a sudden the tumor's not growing. But the cancer immunotherapy doesn't do anything. And when we look at a slightly more immunogenic tumor type, which is a KP1, this is a mouse cancer line that does respond a little bit to checkpoint blockade, but it also responds to IL-4 blockade. And these actually synergize to result in very impressive anti-tumor immunity. So I promise you we'll get to humans in a second. I am a human doctor, not a mouse doctor, but we wanted to dive a little more into saying what exactly is going on, because if we can understand mechanism, we have a much better chance of actually, translating these findings into humans. So why is there all this IL-4? These are not patients who have eczema or allergies. Like where is this IL-4 coming from? What is it acting on? How is it sort of disrupting anti-tumor immunity? So I'll take these questions in reverse. First of all, what is it acting on? That helps us find out where it's coming from if we can find out where it's actually acting on. And I showed you the dendritic cells, the professor cells of the immune system, seem to be very responsive to IL-4. So we figured maybe in the tumor, if we take the tumor out and look at it, there's lots of IL-4 there and it's acting on the dendritic cells. And that's what we would have guessed. That was our hypothesis. But when we knock out the IL-4 receptor alpha from all the dendritic cells in the body, you see here getting rid of the IL-4 receptor doesn't really decrease the growth potential. And we also knocked out IL-4 receptor from all the other tissue-resident immune cells, like the alveolar macrophages and the T cells within the tumor. And we didn't really see any impact on tumor growth, which was really counterintuitive. We figured there must be a lot of IL-4 in those lung tumors that was driving things. So we obviously had already known about this concept of emergency myelopoiesis, and we figured, I wonder if the problem is not in the tumor, it's actually in the bone marrow. And we know that cancer is really a systemic disease. Even if you have stage 1 cancer that's localized in your lung, your cancer is hijacking your whole body. These patients are inherently immunodeficient the day that they get cancer. And so we looked way upstream. So we were looking way downstream at the mature dendritic cells. We looked way upstream at the granulocyte monocyte progenitor. And we did this with Florent Genoux. He was a postdoc in Miriam Morad's lab when I was doing my PhD about 20 years ago. And he developed this amazing model where we're able to knock out IL-4 receptor alpha very early on in myelopoiesis. So we can knock it out from these GMP cells. So these are sort of the stem cells that lead to monocytes and neutrophils, which we know are kind of the two bad guys within the tumor microenvironment, if you will. And if you knock out IL-4 receptor alpha very early on, you see a significant decrease in the growth potential of these tumors. But then we looked just downstream and knocked it out of either the monocyte progenitor or the neutrophil progenitor, and we really didn't see any impact on tumor growth. So this basically is telling us that there's a very important moment in time in differentiation of your macrophages and your neutrophils very early on in myelopoiesis, where we believe that there's some sort of imprinting happens. So we think that these GMP cells are being exposed to IL-4 very early on, and that's somehow driving this emergency myelopoiesis, imprinting on your immune cells and getting them, sort of setting them up for the bad future that they have when they're recruited to the tumors. And indeed, if we look at these mice that don't have the IL-4 receptor alpha very early on, if they don't have a tumor there, it doesn't really affect their myeloid cells. So you see the exact same number of these stem cells in their bone marrow, no change. But when you give them a tumor, in normal cells, you see this emergency myelopoiesis. You see expansion of your myeloid cells that are dumping those monocytes into the blood that are trafficking into the tumor. But you basically lose that if you knock out the IL-4 receptor. So it really suggests that IL-4 is one of the key factors in driving this whole concept of emergency myelopoiesis, whether it be in response to a toxic stimuli or cancer. And indeed, when we then look downstream, if we knock this out way upstream, if we look downstream in cancer-bearing mice, you really see imprinting on the monocytes once they get into the blood and imprinting on the monocyte-derived macrophages once they're in the tumor. So it seems like something's happening very early on in myelopoiesis that's then setting up for this entirely immunosuppressive microenvironment within the tumor. So it just sort of talks to you about the axis between the tumor and the bone marrow and how the tumor is really hijacking the bone marrow very early on in cancer development, probably before we can even detect the cancer on CAT scans. So there seems to be a lot of IL-4 doing something bad in the bone marrow. So where is this IL-4 coming from? And so we looked at using a GFP reporter mouse at all the different cells within the bone marrow, all the things that we thought might be making IL-4, like T cells, B cells, ILC2s, didn't see any IL-4. But the type 2 granulocytes, so eosinophils and basophils, these are granulocytes that we usually choose to ignore because they're very difficult to study. They actually were making all the IL-4 in the bone marrow. And you know, none of these cells were making IL-4 in the tumor, interestingly. It was only in the bone marrow that we were seeing this. And I didn't actually realize this, but up to 5% of the bone marrow are these type 2 granulocytes. So your bone marrow is chock full of eosinophils and basophils. And interestingly, when we specifically looked at the basophils, we saw that the basophils here in green were hanging out right next to the hematopoietic progenitors in cancer-bearing mice. So basically, as soon as a mouse got cancer, all of a sudden the basophils were sticking to the GMP cells, and they appear to be pumping out IL-4 and telling those the GMP cells to expand and then go to the tumor and set up shop. And indeed, if you get rid of basophils, tumors don't grow, and you don't see the same sort of emergency myelopoiesis. So it seems like this is using an anti-CD200 R3, so this basically depletes all the basophils from your body. When we deplete basophils from the body, these tumors don't grow. So this is our sort of working hypothesis, is that you have these type 2 granulocytes, eosinophils and basophils in your bone marrow. They're getting revved up by cancer stimuli. They're then secreting a lot of IL-4. This is polarizing and expanding your myeloid progenitors. These dump monocytes into the blood. They traffic to the tumor. They set up shop, and they really allow for tumor growth and tumor metastasis. So final mouse question is, why are the basophils making so much IL-4 then? That's a little strange. You know, what is it that's coming from the cancer? We think that there's these secreted factors. And indeed, you know, if you take basophils and you either incubate them with media from tumor-bearing mice or non-tumor-bearing mice, you see that that's really what makes the basophils make IL-4. And interestingly, if you grind up a bunch of lungs that have tumors versus normal lungs, we saw there were 8 different cytokines and chemokines that were significantly upregulated in the tumor-bearing mice. So it really seems that these might be some of the cytokines and chemokines that are leaving the tumor, trafficking to the bone marrow and revving up the bone marrow. And I looked at this data, and we went back to some of our serum data from my patients, and these are lung cancer patients compared to controls, so just age-matched smoking controls. And we see that in their serum, 6 of those 8 things that we saw in mice, we actually see in humans. And we were excited about that. We were hoping that one of those might be the magic bullet, and if we turn it off, all of a sudden we would disrupt the ability for tumors to grow. But interestingly, it's sort of this gestalt, this cocktail of all these different cytokines that are being made by the tumor and trafficking to the bone marrow that rev up the bone marrow. So you need kind of this mixture of different cytokines and chemokines to act on the basophils to make IL-4 and really drive this whole concept of emergency myelopoiesis. So again, these are tumor signals that are being secreted. They go to the bone marrow, they turn on your basophils, they make a lot of IL-4, you get the expansion of your GMP cells, dumping of these immature monocytes that traffic into the tumor, and this is really a vicious cycle, this emergency myelopoiesis, that we'd like to find a way that we can disrupt this so that we can sort of hit the reset button on the tumor microenvironment and allow the T cells to get back to work. So mice are great. I am not a mouse doctor. I am a human doctor. And so we saw this data and we got excited, and we were very excited by this concept that maybe we could combine PD-1 blockade or PD-L1 blockade, which we're already giving to our patients, and unfortunately in most patients it either doesn't work or works for a while and stops working. We could combine that with IL-4 blockade and we could potentially see some synergy. So we don't have an IL-4, an anti-IL-4 neutralizing antibody, but we do have a IL-4 receptor alpha antibody. So this is Dupilumab. It's the only drug I think that's advertised more than cancer immunotherapy on television. There are dozens of New England Journal papers that are highlighting the use of Dupilumab just in the last 5 to 10 years in a variety of inflammatory and atopic conditions. And a lot of this work has actually been led by Mount Sinai, both our GI group and also the chair of dermatology and her whole group have led to all of the approvals in atopic dermatitis. So as you can see here, we're giving it to kids 1 to 11 years old. This really suggests this is a very safe drug, which it is. 5 of the people on my research floor use this drug on a weekly basis. Really no side effects. And so we said, well, why don't we try this in our cancer patients? So we opened this trial a couple years ago now, where we took 21 of our lung cancer patients that were progressing on checkpoint blockade. So they had received checkpoint blockade and they either didn't respond, or in most cases they respond for a while and then they stop responding. And our goal is to say, hey, can we hit the reset button? And can we sort of turn off that emergency myelopoiesis for a few months and see if we can get your T cells to wake back up and kill the cancer? So here, all we do is continue this PD-1 blockade that now has stopped working. We continue that and we just add 3 doses of Dupilumab. And so this is the IL-4 antibody. So it's the same thing that we're given to our allergy patients. It's basically an allergy medicine, if you will. And what we do here is we always get a lot of biopsies in blood so that we can really see if we're recapitulating the biology that we see in mice, but in humans. And interestingly, in the phase 1b, so this is just the first 6 patients that we reported in this mechanistic paper earlier in the year, we actually saw 2 of the patients had a really nice response. One of the patients went into remission. So he had squamous cell carcinoma. He'd received chemoradiation and was getting immunotherapy. And then all of a sudden he progressed and he had a new lymph node in the middle of his chest and his mediastinum, and he had some retroperitoneal disease as well, very painful. All we did between this scan and this scan was give him 3 doses. We just continued the drug he was already on that wasn't working. We gave him 3 doses of Dupilumab, and his cancer started going away, and he went into complete remission eventually. So this is very exciting. We weren't really expecting this. We were thinking this might be a better option very early on, and maybe not in established tumors in patients where they'd already had their immune system beat up by chemotherapy and radiation. And interestingly, when we take a look at the tissue, we also saw very significant changes. And we actually, strangely, even see these in the non-responders. So even patients that their cancer kept growing, we do see the Dupilumab appears to induce very interesting systemic and intratumoral changes in the immune infiltrate. So here we're seeing basically formation of tertiary lymphoid structures, so infiltration and organization of CD8 cells, dendritic cells, a lot of B cells coming in. And in the blood, we're seeing similar things to what we see in mice. And unfortunately, it's very rare for us to actually recapitulate what we see in mice and humans because we're not inbred rodents. But here, actually, we were seeing very similar trends where you were seeing a significant drop in the inflammatory monocytes. Again, this is only 6 patients, so very preliminary data. And we see an increase in the effector T cells. And when we look at the cytokines using a very broad panel called the O-Link panel that we run in the Immune Monitoring Center, if we looked at blood on day 1, day 4, so 4 days after getting the first injection, and then on the day that they got their 3rd injection, you see a significant early increase in key chemokines like CXCL11, which are important for recruiting T cells, and interferon gamma, which is a marker of a type 1 immune response. And by day 43, we saw a significant decrease in a variety of quote unquote bad cytokines like IL-1, IL-6. These are members, IL-33, members of the inflammasome pathway that really regulate the ability for your T cells to respond to tumor antigen. And also by day 33, we see an increase of key cytokines that are important for activation of T cells, like IL-2, IL-7, IL-15. So it seems like the body, and we saw this again in both responders and non-responders, is responding to this allergy medicine, if you will, even though some of the patient's cancer continues to grow. So based on that study, we actually opened this other trial, which is just giving cemiplimab, so the PD-1 antibody, and Dupilumab to lung cancer patients who are going in to surgery. So 2 weeks later, they could just get a single dose of this, and 2 weeks later, we cut their tumor out, and we see if we're able to induce sort of a vaccinal effect in these stage 1 patients, because we know about 30% of them, 35% of them eventually recur. And we also teamed up with some colleagues at the Ontario Institute for Cancer Research. This is a surgical program led by Dr. Arnaud. And she had seen our data and quickly opened this trial where they gave breast cancer patients either a dose of PD-1 or PD-1 and IL-4 blockade. And they're going to be presenting this alongside us. We're going to both be presenting our studies at SITC in about a month. And so we're excited to see what they saw in breast patients. So we had this working hypothesis that there's these tumor factors that are hijacking your bone marrow and leading to this myelopoiesis. Potentially we can block that with Dupilumab, but I just told you, not everyone's responding to this. And, everyone's cancer is different, everyone's immune system is different. And we never had the delusion that maybe, everyone had a type 2 signature and we were going to cure everyone's cancer. But it really does drive us to better understand the other potential therapeutic targets that we might look at. And this paper came out last week. This is one of our superstar MSTP students, Matthew Park, who's now back in his second year of med school. And the paper has nothing to do with the story I'm going to tell you, but it really is about understanding aging and why aging really is associated with a low level of this emergency myelopoiesis. And as we get older, we get more and more inflammation, and we're basically, a sitting duck or a petri dish for cancer, if you will, as we age. And it's a new understanding of the concept of inflammaging. But one of the things he did was he was looking in humans and in lungs, or humans and in mice, at their lungs, specifically their lung tumors or in the bone marrow. And he saw that these monocyte progenitors, the guys that we were very interested in, do make a lot of IL-1 beta, which we know is a bad thing for cancer. But there's also a lot of IL-1 beta that's made by neutrophils. And a company, Novartis, had tried blocking IL-1 beta in probably about 10 different very large lung cancer trials, and all of them failed, unfortunately. But what Matthew also noticed is that they make a lot of IL-1 alpha. So IL-1 alpha and IL-1 beta, very similar cytokines, but they're not redundant. And they're both very key parts of the inflammasome, which is sort of part of your immune system that leads to bad inflammation. So people always think inflammation is good because your immune system is attacking cancer. There's good inflammation and bad inflammation. IL-1 alpha and IL-1 beta are really driving bad inflammation. They're important for response to infection, but not for cancer. And if you block either of them independently, you don't really see any effect on tumor growth. But interestingly, Matthew then combined IL-1 alpha and IL-1 beta blockade, and he did see a response. So I saw this data in a lab meeting, and we'd been using a drug called Anakinra to treat COVID patients. This was a few years ago, and we were trying to figure out what to give patients because we had no idea how to turn the inflammation off. So we gave Anakinra, and we saw the exact same effect. And this is a drug that's already FDA approved and used for a variety of obscure conditions you only learn about in medical school. But we knew that it was available, and it was exciting because we also saw recapitulation of the anti-tumor effect in multiple other tumor models. So this is an orthotopic model of colon cancer, an orthotopic model of pancreatic cancer, which is extremely resistant to immunotherapy. And specifically, if you focus on these old mice, it's sort of silly that we're studying cancer in young mice because 9-year-olds don't get pancreatic or lung cancer, thankfully. So here we're looking at older mice and who have very different immune systems. And here, by giving Anakinra, we can significantly decrease the growth potential of all these different solid tumors. So it seems like maybe we shouldn't just be blocking IL-4, but we could also potentially be blocking these other mitigators of inflammation. So now we just started enrolling to this clinical trial where we're adding on Anakinra to what we were doing before. So this is just giving you an idea of this concept of a bench to bedside to bench approach, is we really want to rapidly translate our findings in the laboratory into patients, but also be learning from patients constantly, bringing back their samples and learning from them. And that's something actually very unique at Mount Sinai that we're able to do. So in summary, this is where we started about 10 years ago, just giving patients chemo, and unfortunately everyone was dying. We added on PD-1 blockade, and it's a significant improvement, but unfortunately not enough. And so our work is really, trying to identify these novel immunotherapy combos, but while we're doing that, we're also studying these samples so that we can better identify biomarkers, because not everyone's gonna need Dupilumab. Some people might need drug X or drug Y, and only by, identifying biomarkers that really tell us what way did this patient's immune system get hijacked by the tumor, can we figure out how to really unhijack that in a much more personalized way than we can do by just developing a drug for everyone. Because unfortunately, there's no silver bullets in oncology. And obviously our goal is eventually to get to the point where we're curing all of our cancer and everyone else's death is up to the rest of you guys in medicine to fix. So thanks first and foremost to our patients and our families and their families who spend way too much time with us. It feels like my family. This is just a small sampling of the team. The trials that I'm talking to you about really take hundreds of people between our nurses and our research coordinators and all the physicians and scientists in their labs to run these trials. It's really a team effort. And Miriam Murad is really my partner in crime and an amazing collaborator. And finally, I just wanted to say a word of thanks to all the inspiring physician scientists. I've been here for 20 years, and I think Sinai really is the ultimate place for physician scientists. And I was blessed to be mentored and trained by two of the best. Lloyd Mayer was the former chief of GI and immunology. He was one of my co-PhD mentors. And really taught me what it means to be a physician scientist alongside Charlotte Cunningham Rundles. And Barbara Murphy, she introduced me to my first patient after my white coat ceremony as a first-year medical student in 2005. And she was always a mentor and an inspiration, not only on how to be a physician scientist, but she was also a beautiful human being. So thank you.
time for some questions.
So Tom, beautiful lecture. You mentioned a little bit about biomarkers. So do you have any idea whether like the levels of these cytokines pre-treatment, how many the course of response to treatment?
So that's the holy grail. So we actually have about a third of patients. So we finished the first trial and it was 21 patients and a third of them actually achieved stability or a response, which was amazing because we're just giving them allergy medicine. But we need to identify what is the marker there. And we're looking in the blood for some sort of type 2 signature. The issue is that IL-4 is actually at very low levels in the blood. So we're doing some high resolution. We did O-link on the patients, but now we're doing a more high resolution Luminex to try to see if we can really see a signature of the type 2 cytokines. But I think the other issue is that you don't see a lot of these type 2 cytokines in the blood or in the tumor. It's really within the bone marrow that you're seeing most of them made. And so we're looking in the blood, but it's really, sort of peeking through a hole and trying to see if we can figure out what's going on in the bone marrow. But we're doing pretty exhaustive analysis of the blood right now. We're looking at the tissue also, but obviously we ideally have a blood based biomarker that would help us, figure out which patients should get what drugs.
Good. There's a couple online.
Yep.
Read them for you, at least someone. From Dr. Gallagher. Great talk, Tom. Have you seen any adverse effects in people you gave Dupilumab and anti-PD-1 treatment to? Would you expect fewer adverse effects?
That's a great question. We actually are working with some of our dermatologists because we're actually treating immunotherapy-related dermatitis, which is the most common immunotherapy-related adverse event with Dupilumab. And they in Derm they give Dupi to everyone. It seems like we should put it in the water, but they actually are having very nice responses. We're not clear if that is helping also with cancer outcomes in those patients, but so far we haven't seen any side effects with the Dupi.
Yeah, Tom, I love the talk. Thank you. You gave David nightmares when you spoke about the concept that there are circulating cancer mutations in everything.
That's a theory. I don't know.
But can you explain for us what would distinguish an individual who goes on to develop cancer, given that process may be ubiquitous, versus an individual who doesn't go on to develop cancer? What's different about the immune response that's the primary driver?
Yeah, no, I mean, I think that this really goes to the fact that I always tell patients when they come see me that, everyone in the waiting room has a radically different cancer and a radically different immune system and a radically different, germline sequencing. And all of our immune systems are different. I think that the theory, unfortunately, we are seeing more and more cancer in younger patients. I keep on getting 30-year-olds referred to my program, and it's giving me nightmares. But the theory, and this is I highly recommend you guys check out the Science paper last week. It's a potentially transformative paper because what we're seeing is that we saw it in mice, but then we started looking in humans, and we see this very strong correlation with age, with this development of sort of basal emergency myelopoiesis or aberrant myelopoiesis, pathogenic myelopoiesis. So you see more and more, you basically see this skewing in the bone marrow towards myeloid precursors and away from lymphoid precursors, similar to the NLR, which is one of the most basic ways in which we can prognosticate how patients will do in cancer, the neutrophil lymphocyte ratio. But we see more and more of this sort of aberrant myelopoiesis as people get older. And the theory is that sets you up not only for overly exuberant responses to things like COVID, so it might explain why the 80-year-olds were dying and the 20-year-olds weren't, but it also really sets our body up to be receptive to these cancers. So instead of our T cells saying, hey, that doesn't belong here and killing it, you might all of a sudden reach that threshold where not only is your immune system dysfunctional enough, but you have a cancer cell that got just enough mutations in KRAS and P53 and everything else to sort of pass the finish line and allow it to grow. And once it starts growing, that myelopoiesis, that emergency myelopoiesis, then sort of enables it to grow even more. So it really creates this fertile soil for it to grow. Yep.
Well, next question. What is the situation with common cancers such as prostate cancer that do not seem as responsive to immunotherapy?
Yeah, that's a Nobel Prize waiting to be won. We don't know. They do have mutations. They have lots of immune cells, lots of macrophages, so and there's lots of T cells in there. One of the thoughts with pancreatic cancer is it really has a very, it has a slightly different immunosuppressive phenotype. There's lots of stroma. It's kind of a cancer that builds a wall around itself and protects itself from your immune system, recognizing and attacking it. But there's lots of barriers there. We do have some exciting new agents in our unit where we're actually seeing immunotherapy work in pancreatic cancer for the first time, which has really never been seen before. And so I think that we are making progress, but it's definitely, it's one of the toughest cancers because not only does it usually present at a much more advanced stage and patients immediately have, medical complications, but it also has its own sort of collection of immunosuppressive mechanisms. And we probably have to, specifically target that in the case of pancreatic cancer.
We have one more question another question, and this one from Dr. Kraft. Wonderful talk. As someone who uses anti-type 2 biologics frequently, do you see an increase in asthma in your patients? There is an increased risk of malignancy and allergic diseases, so perhaps we're reducing that risk by using these biologics for their allergic disease. And then, have you thought about using anti-IL-5 treatment for your patients given the direct effect on eosinophilia?
That's a great question. Eosinophilia, I'll take that one first. Eosinophilia is a little complicated because it seems like, type 2, it is a type 2 granulocyte. We see eosinophils in the tumor and in the blood. We see an eosinophilia very commonly. And the data there, actually, sometimes patients with eosinophilia actually do better with response to checkpoint blockade. We have no idea why. We don't understand the mechanism there. But it is, it is a type 2 cytokine. It definitely could promote a more, permissive environment for cancers. And so it would make sense to explore IL-5. And there's some other like IL-33, TSLP, other type 2 cytokines that are interesting. As far as Dupi, we were just talking to Cap, is all of a sudden Dupilumab is now FDA approved for COPD patients. COPD patients are typically smokers. These are patients who should be in our lung cancer screening program. And so we're hopeful, and we're going to be able to see this sort of in a real world clinical trial by starting these patients on Dupilumab. And there's only a subset of patients with eosinophilia that are going to be able to get it, I think. But by starting them on Dupilumab, hopefully we'll actually see less cancer in those patients. And so I don't think that we've been using Dupilumab enough to really argue that this is a cancer preventative medicine. It's only been around for 10 years or so, but it will be interesting to see how disrupting the IL-4 axis, might have long-term sequelae in decreasing the incidence of cancer.
So, I think in talking for your collaboration on the our patient, you mentioned that those who get the immune-related adverse events in immunotherapy tend to have a better prognosis from the cancer side, but I was wondering, there's grade 3 and grade 4 immune-related adverse events. What kind of response rate you see to steroids, and how you kind of counsel patients through that process?
Yeah, it's tough because, when we get to most of the grade 3, 4 adverse events, we actually are able to control with immunosuppressants. And so it's not uncommon for us to cause pneumonitis, colitis, hepatitis, and usually we're able to get it under control with rapid treatment. But we do have patients that you guys end up taking care of for very long periods that do not respond, despite high dose steroids. We're giving post-dose steroids, TNF blockade, IL-6 blockade, and we still are not able to bring in the inflammation. And a lot of the times that's because the inflammation has already caused so much damage that it's a foregone conclusion the way that things will go. So I'd say the majority of the time we are able to control very serious adverse events, even things like grade 4 colitis, grade 4 hepatitis, and it's not a guarantee. Like I said, it's sort of a silver lining that there's a trend towards better responses, and it's a significant trend. But you still have patients that develop IrAEs that don't do well, and you have patients that have no toxicity, which are the majority of our patients that get cured of their cancer. So it's, you can't really, that's the tough thing is you can't really tell people. I know our patient really wants statistics and says, tell me exactly what percentage likelihood this is going to happen. We can't do that because everyone in front of us is not a 45%. You're either a 0 or a 100 when it comes to, cure and response to therapy. It's tough, and it's also tough just because it's, these things are so rare and they present in such a motley crew way, and a lot of the times they'll end up going to a community hospital, so they only get transferred after a week of care, that it's very difficult to run clinical trials in this space. It's impossible to run clinical trials in this space, really. And so we're just always trying, and we have an effort going on in the lab where we're trying to get blood and biopsies from patients getting colitis so we can just better understand their trajectory and how we should best intervene, because we give TNF blockade because they have colitis, and we give TNF blockade for ulcerative colitis. So that's why, it basically is just sort of deduced from that, but they're radically different mechanisms of action. And so we really need to better understand these IrAEs and study them more so we can better treat them.
Great. Well, Tom, it's great to see the amazing research that you're doing. So congratulations. And
Thank you so much.